So how are the prices of medicines decided? Well, as with anything that's sold, there's different ways the prices are set. Firstly, let's look at cost-based pricing. In this, you look at the cost of making the product, not forgetting the costs of research and development, licensing, advertising and promoting. You add this all up and add a profit margin, and that's your price. The profit can then be reinvested to develop the next product and to pay shareholders. The benefit of this is that it obviously covers costs, but the downside is that the investors won't want the bare minimum return. For this reason, cost-based pricing tends to set the minimum prices worth being in business for. So to develop on this, the next method is market-based pricing. In this, you have a product to sell and purchasers who want to buy. The vendor looks at who will pay the most and sells to them. The price is the maximum someone is willing to pay, which is good for the vendor. Apart from they aren't on their own, another vendor might also be in the market and charging less. Purchasers will then go over to them and the original vendor will need to drop their prices to stay competitive. So market-based pricing works well for purchasers if there's multiple vendors, but less well if not, and this can be seen with medicines. When a new medicine is launched, the patent means that only one vendor can be in the market, so prices are high. When this expires, generics can enter the market at a lower price, so you'll also see the original product price start to drop. However, if manufacturers drop out of the market, leaving only one in play, you'll tend to find the price goes back up again. So what's the solution? Well, value-based pricing is touted as the saviour. You have a product you want to pick a price for, so give it to patients and measure the benefit and ask the user to pay the value of the added benefit. Perfect. So how do you do that? Well, ideally, a doctor would give a patient a medicine, then look to see the level of benefit, and that would be the price. However, in reality, this would lead to lots and lots of measuring and recording that would swamp the prescriber, making no one happy. So in practice, people tend to look at the trials, do some speculative maths, and fix the price that way. Which is kind of what NICE do when they say use if available at the negotiated patient access scheme cost or similar. And in reality, it's going to be a bit of a mix. Cost-based sets the floor, market-based the ceiling, and value-based intervenes when the market fails and the price threatens to make people cry.